Healthwatch England, and this replaces the local information networks or links, the patient and public involvement arrangement we had prior to that, and for those with a long memory, community health councils. Healthwatch England is a subcommittee of the Care Quality Commission and hosted by it, and it has no direct responsibility for local health watch. Local health watch services are commissioned by local government on the boundaries of local government, and they have a patient and public involvement responsibility, advocacy, and the ability to comment on a whole variety of plans of not just health service, but now expanded to include social care as well. And that includes the right of access to social care, and Healthwatch has an interest in services commissioned by the NHS and by local government from the private and voluntary sector, and the same rights will apply in relation to access to information and to those as well. So Healthwatch is something, to keep an eye on. Councils are also contributing to the authorisation of clinical commissioning groups. That's a process that's underway, and it's estimated only 50% of clinical commissioning groups will be authorised by the time the whistle blows on the beginning of April. That means the local offices of the commissioning board and the commissioning board itself will still be very influential over commissioning activity. Councils can also comment on the approach that clinical commissioning groups take to public and patient involvement, and this is likely to play a particular focus where there are significant service changes proposed, either changes of access or availability, but also changes of provider. And local government for some time has had, since the Local Government Act 2000, has had a scrutiny role to oversee significant changes to health, including the ability to refer those back to the Secretary of State. And that role is extended to include all NHS providers now as well in this legislation. And there's a variety of other stuff coming across, and the relationship I've described already with Public Health England that's part of that new responsibility. So, lots of new stuff. It drops into a context in which local government is over the comprehensive spending review period losing 28% of its funding. So there is quite a serious capacity issue in relation to both senior and middle management in local government these days, but also a diminishing resource base for key services, which I could speak to you at length on, but possibly as another subject. So, who does local government have to get to know? Well, it needs to get to know you and take that as read. But strategically, it's a whole new ball game with the NHS Commissioning Board. In some respects, it echoes previous instances when the NHS has been more at arm's length from the Department of Health than has been the case latterly. And because of the looser political governance the Commissioning Board has with the Secretary of State at arm's length, the Commissioning Board will be an extremely powerful organisation. And from a local government point of view, it's really important that it maintains its intent to be permeable to influences, but also to be interested in how services can be best organised in the interests of the patient and individual and their carer. The NHS Commissioning Board will still have quite significant sub-regional and local arrangements. They are not the same as the SHA arrangements, but they have some of the similar responsibilities. And where clinical commissioning groups are not authorised, these will be powerful players, I suggest. Local government is finding it very easy, actually, to begin relationships with clinical commissioning groups. In many areas, once the fight has died down in relation to boundaries, as I described earlier, fences are very important to local government. The common cause around seeing the patients in their broader context, seeing the wider determinants of health, seeing all the things that affect people's lives and fill up surgeries that aren't immediately to do with illness, we've found easy and ready cause with, and I hope that's something we'll be able to build on, so the clinical commissioning groups don't lose that focus and don't become just agents of the delivery of healthcare or ill healthcare. And we're doing our best through the way that we build up the health and wellbeing boards, and indeed the ways in which councils are looking at delegating budget and sometimes staff to primary care through clinical commissioning groups. We're looking at that as a very positive way in which we might take things forward. The intermediary body in the system is commissioning support organisations, which replicate some aspects of the PCT. And these organisations, certainly as far as I'm concerned, are quite mysterious organisations, often with quite a large footprint. And they're doing certain things on behalf of things the PCT did before and things collectively on behalf of clinical commissioning groups. One of the key things I think they're going to hold is intelligence about the use of resources and indeed related information around patient activity and issues of that kind. So I suggest they're organisations that I need to get to know more about, and you certainly do too. And then you'll know that the various arrangements that the strategic health authorities had for regional specialisms, regional care pathways and related issues are replicated in the idea of regional clinical centres. And those will remain in place, but without a formal status in relation to the local commissioning activity. And I've described Health Watch locally. One of the things I didn't describe is that Health Watch has a seat at the Health and Wellbeing Board. So as well as contributing feedback from patients and raising concerns and being an advocate of patients, they also sit in on discussions about future intentions and are part of a decision-making body that's signing up to some of these strategic issues. That's a tension that we'll see how it works out in practice. So, the challenges that these arrangements face, well, the most difficult one is the changing roles, the changing faces and the changing people and relationships as far as local government is concerned. Local government has been the fixed point during quite a difficult period for the NHS as a period of turbulence, change in roles, change in structures, things moving around the system and indeed quite a significant amount of capacity being lost to the system for a whole variety of reasons. I've heard it described that the NHS is probably best described as a shanty town. Its buildings are only really put up for 2 years and then they're demolished before other buildings are put up. Well, local government, when you go into many county council buildings, you're going into a building that's been there largely unchanged since 1890, I think, when county council were concerned. That's both a good thing and a bad thing, but they look and feel very solid in a changing context. But as I said before, both sides are facing significant resource constraints. The scale of savings required by the Nicholson Challenge from the NHS is completely unprecedented, and at the same time local government is very, very constrained. It's estimated recently by a Local Government Association that if you project forward current demand for children's services or children's social care, adult social care and waste, the statutory responsibilities of top-tier councils, to the end of the decade, I think, you see a situation where there's almost no money for anything else, all the other services, roads, libraries, related issues. So this is why it's really important that in thinking about the funding of the NHS, the issues around the funding of social care are also addressed. Again, the subject of another conference speech. When the going gets tough, boundary disputes resurface in between health and social care, and these boundaries disputes largely didn't completely go away, but in a time when there was more money around in the system, there was considerable scope for investment in services that straddled these boundaries and actually benefited both health and social care. But at a time of resource difficulties, the areas of concern that re-emerge are issues of continuing health care and the continuing availability of free health care for people with continuing health needs, and also the disinvestment in some of those issues of reablement, rehabilitation, and so on, and prevention to a certain extent, which have been critical to managing demand. Every Health and Wellbeing Board has rapidly come to the conclusion that there is a absolutely central shared objective for both parties that they need to find a way of working through. Both of us need to stop people getting into the system who don't need to come into the system by investment in a whole variety of different ways in which people access advice, information, make good decisions about their own health, but also are redirected to other services. For local government, that often means the investment in services that are not straightforward social care services, or indeed don't look like health services, but are important to the way that people manage their lives. And for health and social care, the investment in services closer to home, services that people and particularly GPs have confidence in, that mean that the A&E is not the first point of call, but is very much an admission of failure if people end up there. So the first common cause is to stop people getting to the system who don't need to. The second key issue is to make sure that people go to the right part of the system, the health and social care system. And here there's a lot of evidence of people being in hospital beds who don't need to, and also evidence of poor discharges. And there's evidence of people who could be treated at home, not being treated at home for a whole variety of reasons. And then when people are in the right place of the system, both organisations have an interest in the most cost-effective way in which these issues can be addressed. And you'll know, and you'll bring a whole variety of perspectives to how the NHS can spend less and still maintain good outcomes for people with long-term conditions, frail older people, and mental health, learning disabilities, children's services, the things that matter most to local government. So one of the challenges is actually achieving change in a context where resources are tight. And also there are real challenges about leadership of the system. Local government is very much very enthusiastic about its system leadership responsibilities in relation to health and wellbeing boards, but absolutely key to this working is a presumption of competence in those arrangements rather than the presumption of incompetence. So if both clinical commissioning groups and local government are sort of on trial as to whether they can actually do this, then it becomes a self-fulfilling prophecy that those arrangements will fail. And how will we know those arrangements are failing? People will stop turning up to significant meetings, stop contributing to significant joint activity. They'll send their deputy, they'll send their deputy's deputy, and in the end, they'll send the most junior person in the organisation or no one at all. So that's a real challenge to maintain the impetus of this, and that's something we're putting a lot of time into from a local government point of view. The other issue really is about how these partnerships can be authentic in the recognition that there's something in it for both sides by coming to the table and working together on these major challenges. And too often, discussions about integration, and there's a big renewed interest in integration in the political circles again, are often about if only local government or other parties behaved in different ways, then the health service would be better off. The issues here, as I hope I've demonstrated, are that there's a win-win for both sides in looking to the contribution both can make to help the other. And the key issue here is about how money moves around the system, because the gains from partnership are often in the part that's not made the most investment to get them. And then it goes without saying that these arrangements introduce politics into the health service, and I have heard an awful lot of people expressing a great deal of concern about political interference in the NHS, about bold decisions not being made, about politicians being very parochial, and also about the failure to grasp some of the complexities of what's required in that respect. And that may be true, but it's also true of central government, politicians. There are major decisions that the NHS needs to make at a national level too that need political bravery. But my experience of working with senior politicians, and I'm talking as someone who's closed many institutions and radically changed services with political support, is that you do need to invest time in explaining the case for change. And very often, a discussion with a senior politician about what you're trying to achieve exposes how weak the argument actually is before you even get in front of the public and the press, where the issue could well be destroyed. There is a good track record, particularly with the closure of long-stay hospitals and other issues of common cause being found between local and central bodies like the NHS on the things that need to change. And politicians, once convinced, will demonstrate considerable bravery in sticking up for the things they believe to be right. Just don't ask them to do it 6 months before an election. So finally then, what are the new opportunities that come from this? And I've touched on most of these as I've gone through my presentation. The greatest benefit, I think, for the health service and for local government is to look at a place in the broader context of the whole perspective. Is very much helped by having public health in local government, but it's also helped by having a more strategic approach to place. And local government brings to the table its responsibilities for economic development, for transport, for planning, for education, and a whole variety of other things, which contribute to, as I said before, these wider determinants of health. It is a significant bonus for the NHS to have direct access to the leader or mayor in an informal setting where you can discuss in detail the case for change and what needs to happen, and to secure agreement to that. The alternative is to try and seek time, to try and engage their attention in something often cooked up and presented as a ready meal at the end of the process, rather than explaining the case and developing some of these issues together. I think these new arrangements bring a fresh impetus to thinking about how health care and housing support policies can be brought together in local government. And it also does provide a much better opportunity, I think, for engagement with the leaders of health and social care in a place. And again, that should be of use to you in your various roles. So, friend or foe? My argument was, and it remains, that this is a friend you've yet to meet in many instances, but I think it's worth spending time doing that. You need to understand more about what motivates councils and politicians. You need to talk to people like me who've been around the block a few times, but also talk to politicians directly themselves. Many have come to their political role as a result of experiences in public services or in other services. Many are highly successful business people as well, and they bring a lot to discussions, as well as a sense of place, which many of us lack. There's an opportunity for us to focus on health, and the discussion to be about health and not just about illness. But it's really important, if you're going to make friends success with local government, that you understand the complexity of the decisions that they have and the complexities of leadership of place rather than leadership of service or business. And that is that many of the things you're trying to achieve to get change, the levers are in other people's hands, and you're trying to work with them for them to release the lever, or for your lever to be pulled at the same time as theirs. And finally, my overwhelming sense of years of working at the boundaries between health and social care and local government more generally is that there is no meeting that, if you could get into it, is the meeting that makes all the important decisions. When you sometimes approach things, you're looking for the where are the decision makers that I can absolutely get to achieve that? Well, the short answer is that partnership, in my view, does not exist in meetings or in structures. It exists in conversations, and it's important that you start having conversations with local government as you make friends with us. Thanks very much.